In this recording, we are going to discuss how whole body MRI scan can become a key component of personalized oncology for patients with metastatic bone cancer. Here are my disclosures. You will see that I will be discussing the off-label use of equipment and software. So when we talk about precision medicine, we're talking about the diagnosis and treatment based on the characteristics of a person. This requires the creation of small cohorts of patients with similar disease biology that are likely to respond to the same treatment and have similar prognoses. The creation of these smaller cohorts enables us to give the right treatment to the right patient at the right time for the right duration. Here are some examples of molecular pathology directed treatments in metastatic prostate cancer. These therapies are based upon next generation diagnostics, and we currently think of gene sequencing as being the dominant technique. We do need some measures of tumor activity. These measures are repeated at various times during the patient journey, and these are then used to titrate treatments and to switch treatments when progression occurs. And this is repeated over subsequent treatments to try to keep the volume of disease as low as possible. So how good are current imaging tools for detecting the presence, volume, viability, and response of metastatic bone disease? Another way to put it is, are they fit for advancing the precision medicine agenda in metastatic bone cancer? I would state that in 2017, we are poorly served by our current techniques. We are unable to accurately predict which patients have metastatic cancer and its extent. So oftentimes, when we think patients have M0 disease, they have oligometastatic disease, and when we think patients have oligometastatic disease, they in fact have polymetastatic disease. The volume of disease and its distribution really does matter. Here's some recent data published in 2015 showing that in patients with metastatic prostate cancer, the presence of high volume disease benefits from the addition of docetaxel to ADT compared to ADT alone, but that this benefit is not as great for lower volumes of disease when ADT treatment alone would probably suffice. Another problem that we have is that we are unable to identify who is not benefiting at an early time point after starting treatment. As a result, we fail to detect primary and secondary therapy resistance, which impedes the progress of patients to alternative therapies that may be available to them. Let me show you an example. Here is a patient with castrate-resistant prostate cancer being treated with enzalutamide. At the screening examination, we can see that there is retroperitoneal nodal disease and the bone scan is negative. After 13 weeks of therapy, the PSA is well suppressed. On the diffusion sequence, we can see that the retroperitoneal lymph nodes have responded, and of course the bone scan remains negative. At week 25, we have a single lesion depicted by the arrow, which indicates the presence of therapy resistance. The bone scan is negative. How do we know that this is a new metastatic deposit? Of course, we've got the prior 2 scans with which to make a comparison, and that tells us. Furthermore, we can zoom in to this area and show that there is an unequivocal new lesion. Thus, this is disease progression. Of course, the standard of care is the bone scan, and we note that the PSA is well suppressed, so the patient continues on the same treatment. And at week 37 we see 2 new lesions on the bone scan with 5 lesions on the whole body MRI scan. Does this constitute progression? The answer is no, not at this stage, because in the setting of a clinical trial, bone scan progression needs to be confirmed by another bone scan at least 6 to 8 weeks later. And we see him again at week 49. Now the PSA is increasing. We have 7 bony lesions. So the actual date of progression was week 25, depicted by the whole body MRI scan. Polymetastatic disease at week 49 confirms progression. This need to wait to confirm polymetastatic disease progression before declaring in a clinical trial that progression has occurred results in delays in starting the next therapy and may put this patient at a disadvantage. Most of you will say that guidelines recommend CT scans also, so that should be okay. Well, that is true for soft tissues, but one has to be careful in the bones. Here I think there can be real issues. So what are these issues on CT scans? Well, progression can occur in front of your eyes and you can't even see it. Let me show you an example. Here's a 59-year-old female with metastatic breast cancer, and we see her in October 2015, and we note that she has metastatic bone disease, poorly depicted on the CT scan, but well seen on the MRI scan as these focal areas of high signal on the diffusion weighted images. She then is treated with aromatase inhibitors, and she's followed up by CT scans, which is the clinical standard of care. She's re-evaluated in the middle of March 2016 when the CT scan is reported as normal, and it's very difficult to see any change compared to October 2015. She represents in September 2016 with bone pain. At this stage we can see there's been a dramatic change in the diffusion weighted sequence, and the CT scan is only showing subtle changes. The morphological MRI scans confirm the presence of disease progression, and the whole body diffusion imaging also shows marked increase disease progression. In fact, when you measure the tumor volume, we can see that we've increased tumor volume from 53 cc's to 473 cc's of cancer. So we've gone from a state of small volume bone disease with mild symptoms to large volume bone and liver disease with moderate to marked symptoms. The CT scan at time point 2 does not clearly tell us what was the clinical status of this patient. We don't know if she has progressed through the entire period, whether there was a time of stability followed by progression, or whether she in fact responded and then progressed later. This inability to know what the disease status was in the intervening time point means that we probably lost some opportunities for instituting less toxic treatments when disease volumes were lower and the mutational heterogeneity was less. The other problem with CT scans is that sclerotic progression and sclerotic response are difficult to distinguish, partly because the bone changes are an indirect indicator of tumor viability because it's reliant on matrix interactions of the tumor cells. Here, for example, is mineralization of metastatic bone disease in a patient who's a BRCA2 carrier. Clearly this new mineralization that you see developing in the vertebral bodies represents disease progression, but the same patient, when her treatment is switched, shows this appearance. On this occasion, we see the emergence of new disease also. We see these smaller lesions on the sagittal and on the coronal images. Is this disease progression also? The answer to that is no. This is an example of sclerotic response, the emergence of well-defined high-density lesions, and many of us are familiar with this appearance. Distinguishing sclerotic response from sclerotic progression is quite a difficult task. So is whole body MRI a method for overcoming this? We know that whole body MRI evaluates both the bone and soft tissues. It is sensitive to tissue cellularity and tissue viability. Another one of the advantages of whole body diffusion imaging is that it has application in disease detection and also for therapy response. Let me show you a meta-analysis that was published a few years ago looking at 145 studies in a variety of cancers. The meta-analysis compared PET scans with whole body MRI scans and CT scans together with the current standard of care, which is the bone scans. So you can see that on the CT scan the specificity is rather high, but the sensitivity is somewhat limited. The bone scans performance is nowhere nearly as good as FDG PET scans or whole body MRI scans. Another one of the advantages of diffusion scans is the ability to depict therapy response. So here, for example, is a patient with metastatic prostate cancer being treated with docetaxel. We can see a dramatic change in appearances on the diffusion-weighted sequences, but we see very little change. Another advantage of whole body diffusion imaging is the ability to quantify the apparent diffusion coefficient and then know what the viability of the underlying soft tissues is. So this is the same patient that I just shown you. We can see that before treatment that the skeleton is mostly of red color. That means that it consists mostly of solid cellular tumor. You can see that after 4 cycles of docetaxel we have lots of yellow areas and green areas. This indicates that there is necrotic tissue and microscopic necrosis occurring. And this change is very, very typical of an excellent response to treatment. You'll also notice that there are residual areas of red within the skeleton, indicating areas of therapy resistance at this time. Let me show you an example of this sort of technology being used serially in a precision medicine example. We have a 56-year-old woman who was treated in 2006 with a node-positive, HER2-positive invasive ductal cancer. We see her in 2012, and over the next 4 years she receives 5 lines of systemic anti-cancer therapy. We pick her up in May 2012. We can see that 95% of her tissues, her bone tissue, is in the highly cellular range. We give her radiotherapy to the right hip because she's symptomatic, and we begin on exemestane and Herceptin. What we notice is that she has a very modest response. All we can say is no response is seen, and it looks pretty stable. So we switch her to pertuzumab and Herceptin, and we see a dramatic response with 50% of the tumor improving. We carry on the treatment, and we straight away begin to see areas of therapy resistance emerging, particularly in the region of the right hip, which we had irradiated. And then pretty soon on the follow-up study, we begin to see areas of red appearing throughout the skeleton. She's beginning to relapse, and then on the next scan we can see that 93% of the volume is in the active tumor, active range. So we switch her therapy to lapatinib with capecitabine, and we see a dramatic response. Her skeleton has become entirely yellow and green, indicating an excellent response to treatment. And then on the next follow-up we can see that she has almost completely responded, with only 3% of voxels showing no response. But pretty soon thereafter we begin to see areas of red beginning to emerge, but she still overall maintained a good response to treatment. But on the next scan you can see areas of red emerging, and then on the final occasion we can see that she's right back to where she started, with highly cellular tissue throughout her skeleton. Time to change her treatment now, so we switch her to Kadcyla or TDM1, and we notice that the area that responds is the right hip, which we had previously irradiated. Unfortunately, this response does not last long, and on the next follow-up you can see she has highly cellular tissue all over her body. And we carry on with Kadcyla. She still doesn't show a response, so we switch her to vinorelbine. Unfortunately, vinorelbine doesn't work either, and currently she's on weekly epirubicin and denosumab, and in 2017 she has developed extensive metastatic liver disease. So if we think about where we are, when we have metastatic bone cancer, we have a number of systemic therapies available to us. The current paradigm consists of response assessments which only tell us about progression and no progression, because we're using CT scans and bone scans and symptoms. What we'd like to do is to break this paradigm by using next generation diagnostics, which include PET scans and whole body MRI scans with advanced image processing methods such as I've already shown you. From this we can get multiparametric biomarkers, and we can combine those with CTCs and circulating DNA and serum markers to break the response categorization into response, stable and progression. So to conclude, I think that whole body MRI scan will replace the current ineffective and indirect method of assessing the bone marrow, using bone scans in particular. We know that whole body MRI scans are already in the guidelines for multiple myeloma, and we have imaging standards that have already been published. There's a real potential here to alter diagnostic thinking when assessing response, because it adds a new category that positively assesses the benefit of therapy in bone disease, not just the absence of progression. The question is, will this allow patients to live better for longer? And we await this particular answer. I think that it'll help to deliver the promise of precision medicine for patients with metastatic bone cancer, which of course is the right treatment for the right patient at the right time, and this is where imaging comes in, for the right duration. I'd be happy to receive any comments about this video. Thank you very much for listening.